Basically, revision is a growing challenge, and as narrated by my previous speakers, it's the third most common mode of failure. We need to understand that the cause is multifactorial, and there is no gold standard for diagnosis, and there is actually no standard definition. Diagnosis requires a high index of clinical suspicion, clinical evaluation, serological, microbiological, and of course radiological markers. Diagnosis is very, very important because subsequent management entirely is fundamentally different, and we don't have a specific diagnostic criteria. Now we need to understand why did it fail. The why failure scenario needs to be understood. Sometimes when we are doing uncemented components, we tend to not get it rightly fixed. We hesitate and then it might gradually fail. And when we talk of cemented components, we always have the worry of putting in cement causing bone cement implantation syndrome and not appropriate cementing. Well, there may be failure of the osteointegration process, and there may be mechanical loss of fixation with varus or valgus alignment of the stem, and last but not the least, patient may be a smoker or some other activities may be happening, and there may be biological loss of fixation. So at the end of the day, you need to know the patient history, physical examination, and obviously rule out other alternative diagnosis, specifically tumors. Now history, to very point specific, pain is aggravated by weight bearing, startup pain, femoral loosening, and there is more severe pain when you have femoral loosening as compared to acetabular loosening. And sometimes patient presents with groin pain that diagnoses iliopsoas impingement or tendinitis as well. So blood investigations. Of course, the basic test is ESR CRP, but we need to understand that the CRP level peaks value 2 to 3 days after surgeries, and it gets back to normal approximately 3 to 4 weeks after surgery. So ESR CRP high does not always mean infection. Recent studies suggest interleukin 6 is important, and it is the earliest to rise. Now, isolated ESR and CRP values are not reliable, but IL-6, CRP and ESR likely PGI. Now, coming to radiological assessment, always compare with previous X-rays and understand the stem and the migration thresholds. So, and I'll talk about advanced imaging as well. So, when we talk about radiological criteria, we have more than 10 to 15 things which we need to see. So, subsidence is the gold standard, and different stems have got different subsidence threshold level. There may be lytic lines. Lytic lines has got its own implication. If it is more than 2 mm, it is indicative of loosening. And groin zone understanding is important. Sometimes you might do a good work, but you have osteolysis and bone resorption, and sometimes it is patient factor related. Altered position of the stem. You have put in varus or valgus, and at the end of the day, it will eventually fail. Quality of cement mantle, which I have talked about. Cup migration. Apart from doing our best, there is cup migration due to aseptic loosening, implant deformation. Some common signs, pedestal signs, spot wells, and HO. These are the things, 10 things which needs to be looked at the normal X-rays. And at the end of the talk, I'll show you how do we look at the X-rays. Sometimes you have subtle focal area of loosening, and that might lead to whole implant aseptic loosening. So at the end of the day, what we do ESR, CRP, and maximally IL-6. If you are doubtful, you can go for aspiration, and when you do an aspiration, see the percentage of neutrophil, see the white cell count, send it for culture, and send it for extended cultures, that is 14 days at least. Talk to the microbiologist. These are some criteria to take about. Now, one thing is very important, DEXA scan. We seldom do it, we should do it, and a special piece of software, the named metal removal, is special software is available. You can analyze the groin zone and make sure you make it as a protocol. DEXA scans have become available everywhere. And different stems have got different types of, like cobalt chrome stems are found to be stiffer, therefore associated with greater periprosthetic loss of BMDs. Similarly, there are other studies which shows that there is no loss of BMD, but what I recommend, DEXA scan is the good test to do it, and pre-op, and it should be done at the end of 2 years minimally. Now coming to the PET scan, I think PET scan is available at most of the centers, and recent studies suggest accuracy of 91%, some studies suggest accuracy of 74%, and the basic principle is uptake of the dye, cellular mechanism. But there are various studies which has shown different level of specificity and sensitivity which we need to understand. But the another basic test comes is the bone scan. Bone scan, we commonly do it, and it is very good, but we need to understand how a bone scan is interpreted, because you have to see the four phases and understand it yourself and take it from there. So bone scan, PET scan. So there are studies which have shown comparison of PET scan versus bone scan. So FDG PET scan is more superior than MDP bone scan. So PET scan is more superior, and when you are talking of PET scan, you have to analyze the zones. So if you are only in uptake of FDG in soft tissues along with all the 5 zones, then it is suggestive of infection. Whereas 1, 2, 3, 3B, 4, A, B, C, these zones, these are aseptic dosing. So you need to understand the PET scan. You should not rely on the nuclear medicine people. It is infection, or because they always say clinically correlate, and then you are stuck up. These are some limitations. PET scan and bone scan, costly. In pregnancy you can't do it. Bone scan is easy to do it, less cheap to do it. Now coming with MRI with Mars. So MRI with Mars has shown to be superior than CT and radiographs in quantifying osteolysis. Now coming to advanced techniques. Now advanced techniques, radio stereometric analysis. I don't know it's available in Delhi or not, but it's not available at my place. And there are concepts of radio-labeled antibiotics as infection-specific radiopharmaceutical concepts. So basically, radio-labeled antibiotics are metabolized and allowed precise infection localization. These are some things which has been hypothesized, but it is not widely used. Yes. Last but not the least, remember your old friend, old is gold, and emerging technologies in future directions. You have smart implants coming up, and this is one of my algorithm which I follow. So at the end of the day, what I would say, just have a good clinical suspicion, take it from there, be prepared, over prepare, go, and if case of any infection doubt, go for 2-stage revision in Indian scenario. Thank you.